wanted to tell you that I really appreciated the last last talk of Dr. Musa, who introduced several concepts regarding the limb-girdle muscular dystrophy. This is a very difficult, I would say, field, and is a growing field because you know that limb-girdle muscular dystrophies are very heterogeneous genetic disorder, and we have a growing evidence of different kind of genes that made a problem even in the classical way to classify them. So these are progressive muscle disorders, of course involving predominantly the proximal muscles, but not only, to be honest, and they are usually identified by histological signs of degeneration and regenerations in muscle. We can have autosomal or dominant inheritance, and you can see this is a quite famous cartoon where you can see that there are a lot of proteins that are involved in the different kind of limb-girdle muscular dystrophies. And what is to be outlined is that sometimes, although we have one specific protein involved, other proteins that are really connected with the same protein could result defective, secondarily defective. And as I told you, there is a big problem now because usually the current classification designated the autosomal dominant loci as LGMD1 and the autosomal recessive as LGMD2. But with the series of 2, we have reached now the Z, and there is the necessity to change completely the classification. And I'll show you, this is a classification that has been reported in 2018 by a group of different groups, but specifically this was included in a recent paper done by Margherita Milone and her group. And you can see that, for example, those forms reach the letter Z. So this is the situation at the moment. And this is why, because you can see that LGMD are strictly connected with other kind of series of different specific phenotypes. And the colleagues have already discussed about distal myopathies or congenital myopathies or even Emery-Dreifuss myopathy. So there is an overlap for some extents between LGMDs and even metabolic disorder myopathies are sometimes overlap. But this, to make the situation even more complicated, we have to take in mind that apart from the classical proximal phenotypes, same genes can produce also distal phenotypes, and same genes can produce also at least at presentation cardiomyopathies or very congenital picture of muscle dystrophy. And apart from this, it's to be evaluated also the extramuscular involvement that you can find in several kind of LGMDs. For example, where, as in alpha dystroglycanopathies, we were discussing just a few minutes ago about the involvement of brain in a different kind of muscle disorders of the liver, of the heart, which is not uncommon, or eye, or skin, or as I suggested before, there are some cases where also neuropathy is present. So this is the very complicated case. And I can tell you that a lot of groups, expert groups, have tried to classify the patient seen in their place. And for example, in this case, there is a very large number of patients with GMD. And you can see that there is a progression of different levels of identification, but still, when you have to make the diagnosis, we can hypothesize that 25–35% of the cases you have in your center are still not diagnosed. And how can you make the diagnosis? Of course, as I just said, it's important to have a very precise and accurate story of the patient and to examine the possibility that other kind of organs are included, because this can address your further diagnosis. Serum CK can be high, can be very high, or can be just elevated. Electromyography usually is quite helpful because it can give you the possibility to evaluate a myopathic phenomenon, because sometimes when you have to deal with the patient with proximal weakness, you may not have a myopathy, you may have a different kind of a neuromuscular disorder. So neurophysiological examination can give you some response in this sense. And as Dr. Musa has outlined, muscle MRI, and I also outlined regarding the metabolic myopathies, the muscle MRI, and I'll give you some results just a few minutes later, are very important to give us the possibility to separate one entity from another, but not always, unfortunately, because it's also important to know at what stage you perform your MRI. Sometimes it's very clear the pattern you can get, sometimes it's is less defined. And of course, today there is the run towards the genetic study, which is of course true, and there are different kind of genetic studies you can perform to assess the diagnosis in limb-girdle myopathies. But as it has been already suggested in several cases, if you don't have a precise diagnosis after the genetic examination, you really need to go back to the muscle biopsy. That can be very helpful. So serum CK in this kind of disorders is usually quite increased. The conventional EMG can give you a myopathic pattern, or might be some neurogenic aspects. Muscle biopsy, it's quite different from one kind of LGMD to another, because you can find fibrosis or regeneration or target fibers, central nuclei. It depends on the different types. But sometimes it's very difficult to have a precise address. But you still have the tool, an important tool, that is immunohistochemistry, because if you apply specific antibodies, you can have some address for your diagnosis. But let's go to the MRI. MRI is very important because apart from showing what is really defective in the different muscle groups, can give us the severity of the involvement of different muscle groups, can suggest specific pattern in a different kind of forms, and but totally speaking, sensitivity is about 50%. If you look at this very complicated picture, you can see that apparently you have a very clear pattern for different kind of limb-girdle syndromes, but these are the well-known pattern. So maybe you can get the MRI earlier, and the picture is not already well defined as you expect. And here, for example, we are describing some MRI in a patient with calpain, and you can see that, for example, at the beginning, the involvement of gluteus is different. Might be gluteus minor or medium, or the medium one are more involved than the maximum, and going ahead, all the gluteus are highly involved. Or if you look at this different type, which is the dysferlin pattern, you can see that at the beginning, for example, you have apparently the proximal muscle, they are not involved, but going ahead, apart from the distal pattern, you also will have in a long run also a clear involvement, a full involvement of proximal muscles. And here, for example, another kind of pattern, you probably, I don't know if you have in this country cases of anoctaminopathy 5, which is more, apparently is more confined to the Northern Europe, but also in the Central Europe now is present. And you can see, and this is also, you can see that at the thigh level, the posterior muscle are more involved, but sometimes, clinically speaking, this is not very evident. So in this case, MRI can help to have a more clear idea about the myopathic pattern. So we were discussing a lot also today about the use of genetics in more specifically talking about limb-girdle myopathies. And till not many years ago, the Sanger sequence was the very long way to get diagnosis, and sometimes you were not able to do it. But now there are different kind of techniques as whole exome sequencing or the NGS, and both of them can be able to give you a response, but not always. As I said, there is still a level of 30% of response that's not very clear. But it's important to take in mind that you have this opportunity. In the last years, so several genes, at least 5 or now I think is about 7 or 8, have been discovered using these techniques. And why we should use NGS? Because sometimes we think that we are going to look for a specific gene, but it's not that one, with Sanger, for example, and we really need to have a larger number of genes studied. Or, for example, when there is the famous discussion about the second mutation, we were discussing this morning, because sometimes you can get one mutation, but the second one is still lacking, and in this case, NGS can be able to discover the second one. Or, for example, when there is you don't have any clue about the direction, the genetic direction to go. So in this case, and also we have done, as I showed you this morning, talking about Pompe disease, when we studied over 500 cases of unknown limb-girdle disorders, there were very significant results, and I'll show you later. And this was one of the experiments we have done with a specific search for LGMD diagnosis in an Italian group of patients. And here you can see the results, and you can see easily that the most relevant group are calpain and dysferlin, red and yellow respectively. But what we have done in over 500 patients was also represented by different kind of results. There were some results regarding the age of, at least age of onset, some other regarding specific aspects of different kind of limb-girdle disorder. You can see in the last row, there are peculiar aspects of different kind of Lamb-Girdle syndromes, at least in Italy. And at the end, there were some suggestions. For example, muscle biopsy where there is a severe connective tissue increase, for example, in calpain. Saying calpain is involved in CK levels that are not very, dysferlin very elevated CK levels. Calpain can have a cardiac involvement. Calpain have a respiratory involvement, and so on. If you look at the specific kind of disorders, you can have some ideas about what is the meaning of cardiac involvement or respiratory involvement in a specific case. And this is the result of this specific graph here. You can see that cardiac and respiratory involvement are more or less frequent in different kind of Lamb-Girdle disorders, and also the mutations can be more often present in different kind of disorders. And apart from this, another important consideration regards other kind of Lamb-Girdle presentation. In some cases, there are, for example, here, this case is a very clear winging scapula, and this kind of this case was thought to be an FSH at the beginning. Then, after the study, the genetic study was determined as a calpain deficiency. Or this one, which is another dysferlin case, or this one, which is a sarcoglycanopathy that has been determined by immunohistochemistry, or this one, which is a fukutin-related protein, again related to the diagnosis was suggested by the immunohistochemist. But other cases are totally different. For example, this is a woman that came to our observation because of the muscle weakness, and in the following 6 months also had an important involvement of the axial compartment. She was not able to stand up from the chair, if not supported, and had a very relevant waddling gait, a positive Gowers maneuver, and there was definitely a proximal weakness proximal weakness at the upper and lower limb. CK was around 1,000, and electromyography was positive for myopathic processes, and this was the muscle biopsy. And she definitely had an inflammatory myopathy, a polymyositis, and she's been treated with prednisone and azathioprine with a full recovery after 6 months. So sometimes it's difficult, if there are no specific clues, to reach this kind of diagnosis, but there are others that are sometimes very difficult. These are a little more difficult. For example, also some myasthenic syndromes may have a presentation with proximal myopathy, as in this case, these 2 cases with DOX7 mutations. The presentation was related to Lamb-Girdle weakness, and they had ptosis, and this is something that we have to take in mind. And but the diagnosis came from the genetic examination. This is another case of myasthenic syndrome. This was a group of patients we studied several years ago, and what we found was that specific marker in this case that oriented the diagnosis was the presence of tubular aggregates at muscle biopsy, and this is a specific distinct entity that is a Lamb-Girdle myasthenia with the tubular aggregates, and this has been studied extensively in the following years by especially a group of Hanslock-Müller, and they found initially 1 gene and a second gene, and more recently even a third gene. So this means that in this case, again, in this case, we really need to use the NGS, because you can see that in that cake, there are several groups of myasthenic syndromes that have been determined by NGS. And last two slides, what about the therapies? And we have discussed just a few minutes ago with the colleagues that sometimes once you get the diagnosis, there are no specific therapies for this kind of disorders, which is, unfortunately, is true, but we have, in any case, assessing the diagnosis is a very important relief for the patient and the family, and avoiding going around a lot, spending money, and having frustrating responses. So this is the first thing. But also, there are some attempts, as you can see, in terms of drug, gene therapy, and cell therapy that have been tried, not always lucky trials. But there are others that are ongoing, and we are waiting for some important responses next year. I can tell you that I've been recently involved in a trial for adults for myotubular myopathy, and according to the previous studies in the children, it seems that this therapy is quite efficient. So in conclusion, we had recently several discoveries in terms of genetic determination of different kind of clinical patterns, and still the general picture is incomplete. We probably are going to discover several other genes, and of course the next generation sequencing and the WES are giving a hand. But don't forget that in some cases also the Sanger sequencing could be crucial to determine the diagnosis. And of course, don't forget also that sometimes it's very important to make diagnosis and establish what kind of other organs are involved, because it's necessary to take care of muscles, but even of heart, liver, and other organs involved. Thanks very much.
Assalamu alaikum. So thanks for staying too late. I think I'm the second one from the last. Hopefully we have had a great lectures and speakers over the last or since morning, but this is the second presentation from the last. So bear with me. We have another 20 minutes, then we all can go home early. So my talk today is about the use of ultrasound in neuromuscular disease. It's not really just in muscle, but also in nerve and diaphragm. What I'm going to talk about over the next 20 minutes, we're going to have a case followed by basics of ultrasounds, then the application of ultrasound in neuromuscular medicine, focusing on nerves, muscle diseases, and then diaphragm. So we'll start with this case. I've actually seen this case during my fellowship in the States. This is a 60-year-old man with right foot paresthesia, mainly in the plantar aspect. Symptoms started 10 years prior to consultation. The paresthesia are reproduced when tapping a tender spot in the posterior thigh. He had no weaknesses back then, and his EMG and nerve conduction was completely normal. And that's his ultrasound that we did at the time. Hopefully it's going to work. Please focus on the middle of the ultrasound. I think it's obvious. So this I'm going through back and forth in the ultrasound in the back of the thigh. So you can see the big oval mass there. And if for any reason, if you have missed that, this is a snapshot of the same mass. And just, you can see it's quite big. It's 3 by 4 centimeters. This computer is quite sensitive, so I need to go back. So it's a 3 by 4 centimeter, like in size, and it's really compressing his sciatic nerve, and that's what gives the patient the symptom back then. And that's his MRI, since we're talking about MRIs. And anyone would like to guess what's the diagnosis? Excellent. So that's schwannoma, bingo. So that's the schwannoma. And the patient ended up having a surgery, so they removed the schwannoma, and he ended up with no complications and with complete resolution of his symptoms. So let's talk about the basics of ultrasound. So what's ultrasound? Really, we're neurologists, we're not radiologists, but the point of this lecture is just to give you a basics of ultrasounds. How can you use it in your clinic to enhance your diagnostic ability? So ultrasound is a linear array transducer, contains a row of several hundred crystal or ceramic piezoelectric elements. So these elements, the idea of those elements is to take that electrical activity in the machine and transfer it to sound waves. That sound wave is going to go and penetrate the tissues. The sound is going to penetrate the tissue, and the sound wave is going to come back or reflect it back to the same crystals, and the crystals will transform these sound waves back to electrical activity, and you will see that in the screen. So that's the whole idea of ultrasound. The cool thing about ultrasound is the reflection depends on the tissue itself, the mass, the characteristic of those tissues. So the bone has a different reflection angle, the muscle, the nerve, the tendons, those kind of structures, and the soft structure, they have different reflection angles. And that's what will give you the picture, the ultrasound picture in the screen. Usually in neuromuscle, we like to use the B mode or the brightness mode. So that really depends on the brightness dots you see in the ultrasound machine. It's not the M mode that our colleague in cardiology, for example, they use quite frequently for echo. There are different types of transducers. So the first one is the hockey stick, and the other one is the standard transducer there. The hockey stick is we don't usually like it. The image, the picture there is quite limited, narrow, and you cannot see it very clearly. But this is the standard one. And again, we don't have the mouse there. But you can see, oops, here it comes, okay. So this is the median. I don't know if you can see. This is the median, there's an M there. And this is the palmaris longus tendon, and this is the radius here, and this is the ulna. So that's how you can visualize the median, for example, in the forearm. Same thing, this is the cross-sectional view, and the one on the left of the screen is the longitudinal view of the median nerve. So the uses of ultrasound in muscles, neuromuscular medicine can be to visualize the nerve, mainly to look for entrapment neuropathies, mainly carpal tunnel or ulnar neuropathy, non-localizable neuropathies, demyelinating neuropathies, and nerve tumors, the first case we showed. In muscle, it's really about the pattern of involvement. We have heard a lot of talks about MRI, using of MRIs, which is great, but this ultrasound is an initial diagnosis. Then it can be useful in selection of the muscle for biopsy, if you're going to go ahead for a muscle biopsy. And it's quite cool to look or visualize fasciculation, and we'll have a video towards the end. Finally, you can look at the diaphragm, looking for the excursion, the movement of the diaphragm with inhalation and exhalation. And also you can look for the thickness of the diaphragm, especially if you have a disease that can involve the diaphragm early in the course of the disease. When it comes to the nerves, we'll start with the nerves. So the nerves, you can either look at the nerve in the cross-sectional area or longitudinal area. When you look at the cross-sectional, the nerve is going to look like an oval or round-shaped structure with a honeycomb appearance. So there is like a fibrous or a white tissue, you're going to see it in a second, that will give you this honeycomb appearance in the ultrasound. When you look at the nerve in the longitudinal view, the nerve is going to look like a parallel lines, either like hypoechoic, followed by or surrounded by hyperechoic lines, and those are the epineurium of the nerve. You can measure the thickness of the nerve, and you can also measure the cross-sectional area. And the abnormal findings you look for in the nerve is either there is an enlargement, you see it with entrapment neuropathy, there is a loss of normal echo texture, the sign of, again, you see it in entrapment neuropathy, signs of edema or edematous nerve. There is the possibility of increased nerve vascularity, you see it with infectious process, mainly leprosy. And the last thing is abnormal structure, extrinsic or adjacent to the nerve, like the muscle tumor, the nerve tumor that we talked about earlier. So that's the appearance that I was talking about. So this is the cross-sectional. You can see this is oval or round shape, and this is like a honeycomb appearance. These all are fibers and epineurium. When you look at the longitudinal view, this is the median nerve, you can see these are the fascicles and surrounded by the outer or external epineurium, and this is the internal epineurium. Again, it's a relatively a new technique using an ultrasound in neuromuscle. So people have been talking about commonly imaged nerves and standardized sites for measurements because we have norms for those nerves in these sites. Median nerve at the wrist, forearm and arm, ulnar nerve at the wrist, forearm, elbow, and arm, radial nerve at the spiral groove, sciatic at the mid-thigh, tibial at popliteal fossa, and peroneal at popliteal fossa and fibular head too. Many other nerves, you can almost visualize every single nerve, including brachial plexus, not really the lumbar plexus, but again, we don't have clear, normal values for those proximal nerves. A couple of studies very quickly. So there is a comparison of ultrasound and electrodiagnostic testing for diagnosis of carpal tunnel syndrome. They had a total of 85 patients evaluated by both nerve conduction and ultrasound. They used the clinical CTS score, and if you have more than 10, you have CTS. They use the criteria of if you have a median nerve more than 10 millimeter at the wrist, that means you have carpal tunnel. Then they use the electrical diagnostic criteria of distal motor latency of more than 4.2. And then they compared between the results of the two studies. And here you can see in the table on the left, the sensitivity of the ultrasound is 89% in detecting carpal tunnel, and it was 89, similar in electrodiagnostic test. But the specificity was higher for the ultrasound, 90% to 80% for the nerve conduction study. The same thing with the positive predictive value. That's a median nerve, so that's a carpal tunnel. So that's a normal median nerve at the wrist. This is the cartoon of what actually you are seeing here in the ultrasound. So that's the normal median nerve, the cross-sectional area less than 10. I assume this is like, I think, 6 or so. This is the compressed nerve. This is the sign of carpal tunnel. And this measurement, I think, is 14 millimeter. And you can see, actually, there is a loss of the echo structure. You see it here, the honeycomb appearance. And also, you can see the nerve is enlarged and also compressed. And that's the cartonic version of it. So that's for the carpal tunnel. Moving to the ulnar neuropathy, also there is a study done by the group and Dr. Kera and his group, looking at the ultrasonography and electrodiagnostic study in ulnar neuropathy, and again, trying to compare between the sensitivity and specificity of nerve conduction versus ultrasound. So they had a total of 30 patients with clinical ulnar neuropathy and 33 patient controls. And in terms of how they come up with this criteria, so that in terms of electrodiagnostic study, if you have an absolute motor nerve conduction across the elbow of less than 46 millimeter per second, or a block across the elbow more than 16%, or a motor nerve conduction slowing across the elbow of more than 15 millimeter per second compared to the rest of the forearm. And they use, in terms when it comes to the ultrasound, they use the cross-sectional area of more than 10 millimeter at the elbow. And again, here you can look at the sensitivity for the electrodiagnostic study is 63, 76 for the ultrasound, specificity 87 for the electrodiagnostic study, and 72.7 for ultrasound. So they come up with this conclusion. Neuromuscle ultrasound is quite more sensitive if the patient has been complaining for less than 6 months, early detection, and the electrodiagnostic study is more sensitive if it's really talking about more than 6 months of complaint. That's the ulnar nerve at the elbow. So that's the normal ulnar nerve, and the cross-sectional area here is less than 10. It's almost 6.3 here. And this is the abnormal ulnar nerve, or the enlarged ulnar nerve at the elbow. And that's actually, you can do it while the patient, like you can have the electrodiagnostic study. And this is the way I was trained. We usually have the patient having the electrodiagnostic study followed by a muscle or a nerve ultrasound. And you can see the abnormal shape, and also the size of the ulnar nerve is quite enlarged. Here is like 15 millimeter. It's not just about entrapment neuropathy. You can also look for the general neuropathy diseases, inherited versus acquired. So in general, this is by Dr. Craig Zedman, my mentor, a nerve cross-sectional area in healthy child and adults controls were usually greater with increasing height. So as you get older, you get a bigger nerve. It's greater in the proximal side if compared to the distal side, and also it's greater or bigger in the sites of entrapment. They have seen that nerves were enlarged in all Charcot-Marie tooth type 1, the demyelinating type, and most of the CIDB, and half of the GBS, and few axonal neuropathies. But they went ahead and tried to sub-specify those, or subdivide those, to having some clues or like practical points to the physician. So they tried to compare between the CMT demyelinating, CIDB, GBS, and multifocal motor neuropathy. And they came up with this criteria. Either you have a type 1 mild enlargement, which is only one side, less than twice of normal side. Type 2 is you have two sites of enlargement. One is twice the normal, and one is less than twice the normal. And type 3 is a diffuse enlargement, more than two sides of twice normal size. And you can look here, and you can actually apply this in your patients. In the CMT patient, most, if not all patients, they have the diffuse type 3 enlargement. Then in the CIDB, they have what they call it regional or patchy enlargement, actually, which goes with the pathophysiology as an acquired patchy disease. And then with the GBS, it's mostly either no enlargement or mild enlargement, and the same thing with the multifocal motor neuropathy. So to conclude in this, talking about this paper, it's quite helpful when it comes to CMT and CIDB. You can somehow have a better diagnosis or a better clue, and it's not a uncommon scenario that we face a CIDB patient. We're not sure if it's really a CMT or a CIDB before doing the genetic. The other thing is the tumor that I talked about, so schwannoma versus neurofibroma. Schwannoma is a tumor coming from the Schwann cell. Neurofibroma is coming from the nerve itself. And the schwannoma can be central or eccentric. And in general, the schwannomas, they have a clearly defined border, but that's not the case with the neurofibroma. And here is an example. So that's a schwannoma. You can see a clear border, one, and you can somehow follow the nerve. So these are the fibers of the nerve. You come down. These are actually the fibers. I don't know if you see it presented very clearly up there. And this is the nerve like going through. So you can see there is something outside the nerve, the schwannoma coming from the Schwann cell, compressing the nerve. It's not the case when it comes to the neurofibroma. You cannot really differentiate. So these are the fibers, and oops, there is an oval mass here, and the picture is cut, but there's a continuation of the fibers here. And the neurofibroma is not coming from all nerves, so it's a fascicular neurofibroma, I should say, because the rest of the fascicles are normal. So let's shift gears and talk about muscles. So when it comes to muscles, we can look at the axial plane or longitudinal plane. So these are the muscles. These are the posterior compartment of the leg. So you can see here, the muscle is usually they say it, or they describe it as equilucent. So it's usually like it's not bright, it's not dark. But you have a lot of like white dots here, which is the fibrous tissue intersecting the muscle fibers. And that's quite common for the posterior compartment of the leg, looking for the different, the superior and, or like the superior and inferior compartment, or the soleus muscle and the gastrocnemius muscles. And these are the longitudinal view, and you can see actually the fibrous band here. And that's actually your clue. When you examine the muscle using ultrasound, you know that you are at the soleus/gastrocnemius level. That's the normal muscle. But here is the abnormal muscle. So this is the normal muscle, and this is the abnormal muscle. So if you have a fatty infiltration or a fibrosis or fibrotic changes of the muscle is going to change bright. And people have been using muscle ultrasound, which I'm not going to talk about in this 20 minutes, but people have been using muscle ultrasound like they use the MRI muscle to try to understand the pattern of involvement of a disease in congenital muscle dystrophy or myopathies. So it's quite useful if you know how to navigate through the ultrasound. It's not an easy test to use, especially if you're starting using it, but with time you're going to get used to it, and you will have an idea exactly, or a clue which muscle you are looking at. Talking about an acquired muscle disease, not just congenital, this is the inclusion body myositis. So this is a study looking for the inclusion body myositis. As you all know, with inclusion body, they have the flexor forearm weakness. So they look at the echo intensity of the flexor digitorum profundus and flexor carpi ulnaris, and they compare between the two muscles. And there was a clear difference, almost 100% in sporadic IBM, and 33% in polymyositis dermato, and 33% in ALS. And here is the picture. So you can see this is the normal, this is the FDB here, and then this is the FCU. So they use A for FDB and B for FCU. This is the IBM patient. You can see there's a clear atrophy and brightness, or echo brightness of the FDP, but the FCU, it looks close to normal, if not normal. And the same thing here with the polymyositis. Yes, there is a changes, but there is no difference between this and this muscle, the FTP and FCU. Same thing with ALS patients. So there was a clear difference between FTP and FCU using ultrasound. This is the cool video about fasciculation. So you can see the fasciculation here. So the contraction of a group of muscle fibers. Sure, you can see it clinically, but sometimes you can use this as a cool study. You can look at the fasciculation at the muscular level or the muscle level. Okay. Last thing I'm going to talk about is using ultrasound in diaphragm. It's quite useful, especially if you're not sure if your patient is having a diaphragm paralysis or a diaphragm weakness. This is a study. They looked at the diaphragm. If you have a patient and you think he has a myopathy or a neuromuscular disease and he's ventilation dependent, he failed extubation several times, you're not sure if it's really a diaphragm problem or not, and you use the ultrasound, they found that it's quite sensitive and did not miss any patient with a muscle problem or expected neuromuscle problem. So this is an 82 abnormal hemidiaphragms clinically. 76 had abnormal sonographic findings, atrophy or decreased contractility. And 49 has a normal diaphragm, and none of those had a false positive ultrasound. So even if you're seeing a patient, you know it's not a neuromuscle, it's like a respiratory problem, and do an ultrasound, your positive predictive value is going to be it's good. So you're not going to miss anyone, and you're not going to overdiagnose anyone with a muscle disease. And you can see it here in the table. This is a paper from neurology. These are the diaphragms. So what we're looking when we do a diaphragm ultrasound, you look for two things. One, the thickness of the excursion. First, the movement of the diaphragm with inhalation and exhalation. And you have to compare between the two sides. And two, look for the thickness of the diaphragm. You can measure that during exhalation and inhalation. And this is they call it the anterior subcostal view. And actually, it's the best view. I have to say there is always a limitation if you have an overweight patient. Sometimes it's very difficult to visualize the diaphragm. And you can see the diaphragm here. Maybe it's not good. This is the diaphragm here between the two ribs. This is one, this is the second rib, and there's the diaphragm. And you can see with inhalation and exhalation here the difference in sizes between inhalation and exhalation. And that's my last slide. So to conclude, ultrasound can be useful and an extra diagnostic tool in neuromuscle clinic. It's really operator dependent. And it's not just about measurement. You have to use qualitative and quantitative measures. You have to look at the nerve itself, the echo texture of the nerve. Also you have to measure the nerve and look if there is any enlargement. You can use it in Botox injection in spasticity. You can use ultrasound-guided LP injection in patients with severe scoliosis, like an SMA patient now with Spinraza. And the last thing, the more you use it, the more comfortable you will get with it. Thank you.
Okay, thanks for the introduction. Good afternoon, everyone. So it's my pleasure today to be with all of you today. And I would like to thank Dr. Kobler and Dr. Aisha for the invitation for this lecture. And thanks organizing committee for organizing such a prestigious conference. Here is my outlines. So here is my outlines. as we know, this kind of myopathy is reversible, has a lot of challenging in diagnosis, and in our practice is usually undermissed and underdiagnosis. So generally, endocrine myopathy is associated with hormonally mediated alteration in the muscle metabolism. Any hormone imbalance can be associated with even present with the neuromuscular symptoms. Most of the endocrine disorders are associated with muscular dysfunction. Myopathy is rarely a presenting complaint, and muscle fatigue is more common than true weakness. Here is some of the sign of symptom of myopathy. Patient could present by weakness, fatigue, myalgia, cramps, and myoglobinuria. And in physical exam, we could find muscle atrophy, contracture, and hypertrophy. So this is the type of thyroid disorder, the most common type, thyrotoxic myopathy, thyroid ophthalmopathy, channelopathy, and hypothyroid myopathy. In thyrotoxic myopathy, 60 to 80% of the patient presented by proximal weakness. Patient could present by slowly progressing disease or acutely in the form of thyroid storm, but it's very important to rule out myasthenia gravis and rhabdomyolysis. The mean age of onset is in the 5th decade. It's more common in male. However, hypothyroidism is more common in female. It's characterized by proximal muscle weakness, and atrophy is mainly affecting lower extremity more than the upper extremity. Myalgias and fatigues are common. Distal weakness could be affected in 20% of the patient. Bulbar and respiratory involvement also can occur, and rarely rhabdomyolysis and myoglobinuria in severe cases. The second type of this thyroid disorder can be presented by myopathy is thyroid ophthalmopathy. A patient could present by proptosis or restrictive ophthalmopathy due to infiltration and swelling of the muscle, which is cause increased intraorbital pressure and can lead to compression of the optic nerve and visual loss. It's most commonly seen in patients with the Graves' disease. Enlargement of extraocular muscle can be diagnosed easily by MRI. Treatment may include if refractory corticosteroid, cyclosporin, and orbital radiation, but in simple cases, we have to avoid eye from keratitis and to normalize the thyroid function. This is the other type of thyroid disorder is thyrotoxic periodic paralysis, commonly reported in Asian male. It's characterized by recurrent episode of painless abrupt onset weakness. It's similar in onset duration like hypokalemic periodic paralysis. However, familial hypokalemic periodic paralysis presented in early decade of the life, and thyrotoxic periodic paralysis is later in the adult life. Here is the pathophysiology. Thyrotoxic periodic paralysis is happened due to combination of these factors. Genetic, environmental factor, and thyrotoxicosis is one of the essential factors. And the genetic factor, usually there is a defect of the ion channel or the ion channel subunit. And as we see here, there is mutation of potassium channel, usually happen with high level of the thyroid hormone and genetic susceptibility, causing potassium to prevent potassium to go extracellular. So it will stay intracellular and it cause hypokalemia and alter the excitability of the muscle cell and cause flaccid paralysis. Muscle strength usually return normal with the treatment and normalization of the thyroid function, and beta blocker like propranolol also can lessen and improve the myopathy. Here is some of reported cases. The last one in 2017 of thyrotoxic periodic paralysis could be the initial presentation of Graves' disease. So this case will emphasize the importance of considering TPP in any patient presented with acute muscle weakness, because it's reversible and easy to treat. CK usually normal in the thyrotoxic myopathy, TSH low, and T3 and T4 is high. Nerve conduction and EMG is normal, but however, in some cases could show the myopathic changes. Potassium level also is low in TPP in the acute attacks. Muscle biopsy usually normal, however, in some cases can show the type 2 muscle atrophy, as we can see here. Weakness resolve 2 to 4 months after thyroid hormone normalization. Propranolol can prevent and lessen attack the TPP, as I mentioned before. Acetazolamide is ineffective for the periodic paralysis, unlike the familial hypokalemic paralysis. Extraocular muscle weakness can persist for a month or year after treatment, and immune suppressant and corticosteroid for refractory cases can be helped. Now we'll move to the another entity of hormonal disorder is hormonal insufficiency, like in hypothyroid myopathy. Hypothyroid myopathy can be presented by neuromuscular symptom in 80% of the cases. Patient can present by weakness, cramps, myalgia. All age and sex may be affected, but it's more common in female. And 1/3 of the patient developed proximal arm and leg weakness. Lower limb is usually weaker than the upper limb. Rare patient can develop muscle hypertrophy, rhabdomyolysis, ventilatory muscle may be affected in severe cases. Peripheral neuropathy can be associated also with the hypothyroid myopathy, and patient presented by distal sensory loss and loss of the reflexes, particularly in the ankle. Delayed ankle reflex also can be a presenting sign for hypothyroid myopathy, especially for the ankle. And myasthenia gravis can also occur in association with hypothyroidism. Here are some of the signs of the hypothyroid myopathy, like myodema. Myodema happens when we percuss over the muscle. There is a molding or expansion of the muscle. It's lasting for a second, and it's occurred due to sustained muscle contraction due to delayed relaxation. Hoffman syndrome, also rare but can occur, is pseudo-hypertrophy of the muscle, of the calf muscle. CK usually elevated in hypothyroidism, 10 to 100 times of normal. Thyroxine is low while TSH is elevated. Nerve conduction and EMG are usually normal, but however, in some cases can show the myopathic changes. Muscle biopsy may be required to exclude inflammatory and other myopathies. For treatment, usually patient improve with the normalization of the thyroid function. Thyroid replacement lead to resolution of lab abnormality and symptom over few to several weeks, and weakness can persist 1 year after normalization of euthyroid in some cases. This table showed a review of all type of thyroid disorder. As we see here, most of the types is presented by slowly progressing. Apart from hyperthyroidism can present by acute severe quadriparesis, and the thyrotoxic periodic paralysis also can present by acute weakness. CK usually normal in all type, apart from hypothyroidism can be elevated to 10 to 100 times of normal, and diagnosis depend on the thyroid function, and hypokalemia in thyrotoxic periodic paralysis usually seen, and management is depending on the underlying condition. Parathyroid disorder also can cause weakness. Myopathy are common in disorder of calcium and phosphate hemostasis. 72% of the patient complain from weakness. A secondary hyperparathyroidism and muscle weakness can develop in patients with chronic renal failure. 50% complaining from cramps and paresthesia, and muscle infarct and myoglobinuria could occur due to calcification of the artery and deposition of the calcium in the vessel. CK usually normal in hyperparathyroidism, but could be slightly elevated in patients with muscle infarct. CT and MRI will help to localize the abnormal enlargement of the parathyroid gland. EMG and nerve conduction usually normal unless there is a neuropathy due to renal failure. and muscle biopsy usually showing non-specific changes. And as we know, calcium and vitamin D parathyroidism, the metabolism of the calcium, parathyroid, and vitamin D usually is linked together. Here is just brief to differentiate between primary and secondary. Serum calcium and vitamin D are high in the primary type, while it's low in the secondary type. Phosphate is usually low in both. Parathyroid hormone is high in both type, and CK usually normal in both type. Treatment of hyperparathyroidism, its earlier diagnosis and treatment have led to fewer and less severe neuromuscular complication. A treatment of choice for symptomatic patient with primary hyperparathyroidism is parathyroidectomy, and if there is hyperplasia of all 4 glands, usually subtotal parathyroidectomy can help. And before we diagnose any patient with motor neuron disease, usually, as we know, we rule out the mimicker. One of the mimicker is hyperparathyroidism. So hyperparathyroidism can rarely mimic ALS, and patient may improve following resection of parathyroid adenoma. And most of the patients improved after parathyroidectomy. They didn't have motor neuron disease, but rather hyperparathyroidism related myopathy. And there is rare reported cases of hoarseness, weakness of respiratory muscle, spasticity. Majority of them is ALS and with coincidental finding of hyperparathyroidism. Hypoparathyroidism also rarely can cause weakness, but it's more commonly cause paresthesia and tetany due to hypocalcemia. CK is mildly elevated. Parathyroid hormone is low, and calcium, why they have a high phosphate level. Nerve conduction and needle EMG usually normal, and muscle weakness improve following correction of hypocalcemia. So steroid myopathy is a big topic, and it's the most common cause of endocrine-related myopathy. It's more common in women than men. Steroid myopathy typically affect the proximal muscle of the lower extremity, affecting the hip and the thigh muscle. Distal extremity, bulbar muscle, and facial muscle usually are spared. It's increased risk with prednisone dose more than 30, and the big dilemma is to differentiate between weakness, if is it related to steroid or if it's related to underlying disease. This has happened after the patient putting on steroid and have a long time on steroid and develop weakness. So if the patient is on steroid, high dose, chronic dose, and have steroid side effect is most likely related to steroid. And if the patient is on tapering dose of steroid, is most likely related to underlying disease. This is 2 causes of steroid myopathy. Could be caused by drug-induced, especially 9-fluorinated corticosteroid like dexamethasone. It is less with the prednisone and rarely less with the less dose. Endogenous could be Cushingoid syndrome and ectopic ACTH production. CK usually normal in steroid myopathy. Serum potassium can be low and can worsen the weakness, and sodium may be elevated. EMG is sometimes is abnormal, and muscle biopsy showed atrophy of type 2B fiber. In case of adrenal treatment, surgical when possible, and in case of iatrogenic steroid use, changing the dose or changing to alternative day regimen or changing the type of the steroid to non-fluorinated steroid and encourage exercise can help. In Addison disease can result from adrenal or pituitary dysfunction and may be associated with subjective weakness. Objective weakness usually related to electrolyte disturbance like hyperkalemia and hyponatremia. CK and AMG muscle biopsy usually normal, and symptoms usually improve after proper treatment of adrenal hormones. Pituitary adenoma also can cause weakness, such as acromegaly with hypersecretion of growth hormone. Patient can be presented by slowly progressing proximal arm and leg weakness. Bony overgrowth also can occur and lead to nerve, root, and spinal cord compression. CK usually normal or mildly elevated. Muscle biopsy showed non-specific changes. AMG could show myopathy in 50% of the cases, and we can treat it with the surgical resection of pituitary adenoma. As we see here, this is a acromegalic feature of patient before and after the onset of the disease. Diabetes also can cause muscle disorder, but in the form of muscle infarction. Is usually occur in the setting of poorly controlled diabetes, patient with micro and macrovascular complication, and it's more common in type 1 diabetes. Patient most commonly present with acute pain and swelling in one thigh, also can affect the calf muscle and rarely the upper extremities. As we see here, there is swelling and redness over the left thigh, and this diagram showed the distribution of the weakness is 55% affecting the thigh muscle, and 15% affecting the thigh and the calf muscle, 5% affecting the upper extremities. CK in diabetic myonecrosis may be normal or elevated. Hemoglobin A1C, WBC, ESR is usually elevated also, and EMG demonstrate denervation changes and myopathic changes over the involved muscle. Muscle biopsy in diabetic myonecrosis usually showed necrosis, as we see here, and hyalinized blood vessel with narrow lumen. This is characteristic for diabetic myonecrosis. An MRI also can help, as we see here. This is a normal thigh here, and this is normal thigh of adductor muscle, showed hyperintensity in the muscle and diffuse involvement of the muscle. And here is post-contrast, so all the muscle taking the contrast except area of necrosis is non-enhanced. And treatment is consist with immobilization, pain control, muscle pain and swelling resolve after several weeks. Prednisolone can help to relieve the pain and the swelling. And muscle biopsy should be avoided in such cases to prevent, because the patients have high risk of hemorrhage into the tissue. So before I conclude, I have a quiz to refresh you. 43 years old woman presented with 8-month history of fatigue, muscle ache, generalized weakness. She noted 2.2 kg weight gain despite no change in her activity. She has dry, coarse skin. In the previous 2 months, she has been waking up at night with paresthesia in her hand bilaterally. Examination showed mild proximal weakness in deltoid triceps, mainly affecting the proximal muscle. Her reflex is had delayed relaxation. She had mild sensory loss over the thumb and the index. Nerve conduction study and EMG showed bilateral median neuropathy. Her serum CK was elevated, 400. Serum TSH elevated, while T3 and T4 is low. So, who want to be volunteer? I will take this. Okay. So in conclusion, endocrine disease are generally associated with hormonally mediated systemic alteration in metabolism. The diagnosis of such a myopathy may be more difficult if it's presenting manifestation of endocrinopathy. Muscle fatigue usually is more common in all type of endocrine myopathy than the weakness. All the patients with neuromuscular complaint should be investigated for endocrine causes because significant number of them will recover fully with treatment. Diagnosis is frequently delayed or missed. And serum CK usually normal, and EMG biopsy showed non-specific myopathic changes. Thank you.